So welcome in tonight too, where we do basic arrhythmias. I just want to get an idea of how many of you got to come last night. So if you got to come last night and see our session, you can type in the chat, I was there. You can be on Zoom or Facebook with us. Hey, KJ, what's up? How's everybody doing? Let's get the screen shared so that we are ready to go right on time. Right on time. We're going to do arrhythmias tonight. And yeah, this is day 2 of the 3-day EKG challenge, which is literally one of our favorite things to do. Hey, what's up, Cheryl? Cheryl, your package is going out today because you won our Invite a Friend contest. You run, I think, second place or third place, but pretty darn good. So your gift went out today. Yes, KJ's here. It looks like Matt was here last night. Hey, Lynthia, your package went out today too. So congratulations, you were our winner last night. We have winners every night, so it's exciting. James, what's up? Michelle is here, yay. Let's get Michelle promoted, Ruben, and then Cindy was here as well, yay. All right, so night 2 is just as good because we're gonna do arrhythmias. And then, hello, Michelle. We have a special guest at 6:15 PST tonight. That is the session that, if you recall, yesterday we talked about, and we said that one is not reported, but it is a bonus session. We're going to go in this little segment that is recorded with me. We're going to go through some arrhythmias that are really common. So if you're new, this is going to be super helpful. And then afterwards, we're going to have the non-recorded bonus session with Gary Krause, who is an RN that makes these tools. In fact, we'll be giving some of the way after his session to be mailed out to winners because these are so fun. So just another little fun way to to give these away. It's super fun. So now that we're right on time, let's kick the session off and let's get started. All right, so basic arrhythmias is what we're doing today. Hi, Tori. Tori's here. And essentially, we're going to bring back the concept of last night, where we discussed the 3 questions to ask, right? And let's recap those before we get started, because the 3 questions were, is it wide or narrow, fast or slow, and is it regular or irregular? That's going to help us solve most of the arrhythmias. It looks like Michelle just logged on. Hey, Michelle, what's up? How are you? Our co-hostess, who is going to be bringing our game tomorrow night. Let me just tell you how excited I am about that. I think she's just getting settled in. So we can check in with you later if you want, Michelle. But anyway, we're going to be asking those 3 questions, and then we're going to be going through some of the basics. Now, if you're a student, this is really going to be helpful. If you're not a student, this can be a review. I feel like unless you're working in telemetry, you don't get a lot of practice with arrhythmias unless you see a lot of them every day, right? And if you're in primary, you're not doing EKGs all day, usually. So this can be a little bit rusty. So let's sharpen the blade. Now this is that, oh, David's here. What's up, David? Oh my gosh, so exciting, David. So David, I introduced you guys to David last night, if you recall, and he is our arrhythmia guru, our everything guru, as I mentioned yesterday. But if you see him posting things in the group or in the chat, it's always really full of value. So make sure if he posts anything, you really pay attention. And then this is the session that is going to be not recorded. So I just mentioned this. It looks like Teresa Forsyth is here saying, I'm a retired ER RN. Nice. Just here for fun. That is great, because if arrhythmias are fun, then that, you did the right job for your life, right? And thank you for being a nurse and serving all those years. Nicole says she had a patient with a junctional rhythm today. I was so glad I attended. Oh my gosh, so cool. All right, well, let's kick it off and do some arrhythmias. And let's also answer some questions, because people said, hey, if I miss a class, is it okay? Yeah, of course it's okay. This is just for fun. And if you want the replay, that we have 2 ways to watch them. You can either go to the guides section and go to the day that you missed, day 1, day 2, or day 3. And we also post a replay page, and you can click on it and watch it there. So if you're at work and you can't be on Facebook, you can watch the replay page. And then the workbook, I know Tori's going to post it for us. And then she will basically put a link for you if you want to still get the workbook. It's just a little accompaniment with some fun stuff to play with and go along with. And then the lineup for tonight is basically me, roughly 20 to 25 minutes, and then we'll have Gary come on. And Gary will do probably, I'm guessing, 45 minutes. And it looks like David is tagging some Joseph. Joseph better get in here. If David's tagging you, you better get here. So it's full of good stuff. All right. So this is just a recap. A lot of people said, hey, what's the answers from last night? Here they are. They're also posted in the featured posts. The answers are there in the top of the group. But here it is written out. And somebody said last night, I can't read your writing. I was like, yeah, because I'm a PA, right? So of course my writing is messy. So I think they couldn't read this, which says round. And also this says AVR and V1. So I'm sorry about the writing. Yeah, Tori just asked a really good question. Tori said, what was everyone's favorite thing about last night? I would like to know that too. And then here's the 3 questions written out for you, just to go ahead and remember that you're looking for, do we need to intervene right now? That's always your biggest question about the arrhythmia. And then if you don't need to intervene right now, then what is it? And then after what is it, what do I do about it? And is it a killer? Like, is it going to kill my patient? Like, for example, AFib can be a killer technically if it goes too fast, or if they're not on anticoagulation and they need to be, like they have an elevated CHADS-VASc2 score. Ventricular rhythms, right? Little slow. Agonal would be a killer. Asystole, a killer. There's lots of things that we need to do something about right now. So these are the questions you're always going to ask yourself. And so David is actually doing a class in our 30-day EKG challenge tomorrow. So if you happen to join us in our 30-day EKG challenge by tomorrow, you'll get to attend David's study hall. So that's what David's talking about in the chat. He does a hour-long session every 2 weeks, customized to whatever our members want. So it's a really valuable session, and getting to pick this David's brain is really, really pretty cool. So going over the atrial rhythms first, remember those are the rhythms that are going to have the narrow complex, and they're going to usually be regular. There's exceptions, but we'll talk about that. So all the things that come from the atrium, you've got atrial flutter, which can be regular or irregular, depending on the conduction. You have atrial fib, and then of course, atrial fib with rapid ventricular response. So does anybody know, let's put it in the chat. Does anybody know the number, the heart rate number that AFib with RVR must be over to be called RVR? Rapid ventricular response is what that means. It must be, and KJ put a great comment, you have to know what is normal to know what's not normal. That is a beautiful way to say it. Teresa, okay, this must be Teresa Comas, which is, Teresa's a rock star also in this group, so keep an eye on her. And of course, 100 and over Sharon and Shi Ting, and over 100, okay? So then we're going to the SVT, supraventricular tachycardia. That's going to come on the top, going to go super fast. And then sinus tach is going to be similar to SVT, but slower, and you're still going to have a P wave. And then Wolff-Parkinson's White comes from the top and goes down an accessory pathway. And then premature atrial contractions, okay, can also, yes, come from the top, okay, because they're skinny and they're early. Now, looks like Tori is posting a link to join our class. Thank you, Tori, for posting that. If you want to get in on David's class, you can join us in the 30-day EKG challenge, which we'll talk more about later tonight. But this strip here, I wanted to give you guys a little bit of practice on sorting this out. Now, I'm just going to tell you what happens in my mind, and maybe it's similar to yours. And if you know this rhythm, go ahead and put it up. But what I do is I'm like, and David taught me this, big ugly, right? I'm going to stop. I always tell my MA, do I need to stop, drop, and roll? Like, with the fire things back in the day when you were like, the building's on fire. Do I need to stop, drop, and roll? No. Okay, good. So then I basically look at it, and then I'm like, okay, too fast, too slow. Does it have a P wave? Is it narrow or wide? Is it regular or irregular? So let's go through it and answer all the things. So it looks like Matt got the answer already. Good job, Matt. So this is an irregularly irregular rhythm. It is, honestly, we'd need a 12 lead. This was a computer generated strip. So it looks like these might be wide. We would need to see, right? Because remember, the The wide over 120 would be something to worry about. 120 milliseconds or 3 small boxes, which we talked about last night. And David said, this is his mantra: too fast, too slow, too ugly, gets his attention. So that's a great piece of advice too. So this is none other than AFib. We know that because it's irregularly irregular and there's no discernible P wave. Pro tip number two is if you are looking at a strip, and good job, KJ and Matt, if you're looking at a strip and you are looking for more than a few seconds for a P wave, there's probably no P wave. And it's probably atrial fibrillation. Okay, that's just a pro tip. Okay, so here's what we want to see. This is a normal sinus rhythm. And we want to look at that and we want to say, okay, this is what we're supposed to see each and every time. Of course, if you work in EMS, you're going to see a lot of big, bad, and ugly like David does, right? If you're in the clinic, hopefully not so much, but it's possible. And you're looking at these beautiful discrete P waves. Remember, the sinus node makes P waves, okay? And you're looking at the regularities to the R to R, which is normal. And then this would be under 120 milliseconds, so it would be narrow. So this would be a normal sinus rhythm, anywhere from 6 to 100 beats per minute. Oh, another good tip. See, as I'm telling you, all these pearls. So David said, take a long lead strip, which is always going to be at the bottom of your 12 lead, and you basically fold it in half and put it up to the light. And then if it doesn't line up, it's probably AFib. That's another great way to do it. So like I said, keep your eye on him. Hey, Tanya, what's going on? And let's do the next one. So here's another rhythm. And the question is it regular or irregular? And my first thought whenever I see something is irregular is it AFib? Is it AFib? Okay. So again, how do you troubleshoot this? You go in and you say, okay, is this regular? It looks good here, looks good here, but then that's a different distance. That's not regular. Okay. And so Shi-Ting is all over it already. So is Teresa. So the next question would be, do they have a P? Okay. So I see a beautiful, wonderful, discrete P here, a P here, a P here, and a P here. So this definitely does have P waves, but it is irregular. So this is a sinus arrhythmia. Sinus arrhythmia, it's a benign finding, often found in athletes or people taking a breath. And so sinus pause would be a differential, but you would need basically a longer lead strip at the end of the day to really see if it is a sinus pause or if it's sinus arrhythmia. The age will also help you. So what causes sinus arrhythmia is breathing, usually breathing. But people can have high vagal tone and be athletes and have this. So that usually a younger person is going to be found having sinus arrhythmia. Good question. And David looks for grouped beats. So that's another good point, is when you are looking at irregularity, if you have grouped beats, you always worry about heart block. Okay, heart block is always on the menu for grouped beats. Now, this is a slower rhythm. This is a sinus bradycardia. And we know that because it's under 60, but still has a P wave, and it's regular, and it's narrow complex. Okay, how can we cause this? Yes, very common in the young. Exactly. So how can we cause this? Well, we can give medications. So can you name the medications that you would look for their med list to see if what medicines would you look for? Yes, good, Alejandro. Beta blocker, exactly. You might also see CCB, good job, Alejandro, the calcium channel blocker. You might also see, if anybody, let's push it further. You might also see a slow heart rate if you're on people don't usually think of this, but an AAD, an antiarrhythmic drug. We have all the abbreviations now. We have CCB, BB, and AAD. Okay, so that's sinus Brady. And again, you have to, and digoxin, good one, Danielle. Love it. Love it. Okay, so that could also cause slow. So you need to make sure they don't have a reversible bradycardia. That's something you can actually fix. So the rhythm here, let's do this one. And yes, it can't. So that's a good point too, David. You keep reminding me of all the things. If you have somebody who is super athletic, they can have a low heart rate, and that's a normal finding for them because their heart's more efficient. Now, what's the rhythm here? It's over 100. It still has P waves. And yes, Teresa, it is sinus tach. So Hey, Dana, what's up? So this would be potentially atrial flutter, right, KJ? So if it was fast, and to really ferret it out, you could do something called Lewis leads, which is a special setup of the monitor of the 12 lead. But this is slow enough that it is sinus tach, and there's two common causes of sinus tach. Well, actually, there's more than two common causes, but does anybody want to shout out some causes of sinus tach? What are some possible causes? I mean, it's so common. Like everybody's tacky. Okay, running. Yes. Fever, anxiety. Good job, Michelle Cruft. So these are all good. Pain and fever, that's a good one. Also Linthia. Lots of things. Thyroid, amphetamines, fever. These are dehydration, caffeine. These are great. So we need to figure out the cause, and we need to treat the cause so that we fix the problem. Now, the rhythm here is actually regular. And there is not hint P waves, okay? This wave has a special name, and this rhythm has a special name. So what is the name of this rhythm? And yes, exactly, these are all good. You guys are still giving me causes of sinus tach. I'm loving it. Heat injury, yes, that's another one. So this rhythm, what is this called? I see that Teresa already put it in. These are called F waves. And Nikki, Michelle, and Teresa, yes, this is atrial flutter. Good job, Tanya and Dana and Lynthia. Atrial flutter, these are flutter waves, F waves. They're not P waves. And these are very distinguishable. Yes, okay. So we're looking at the conduction. We're looking at, does it go too fast, too slow? Is it variable or is it consistent? Okay. So this is the none other than the beautiful AFib. We've already seen this. And essentially, the classic hallmark is it's irregularly irregular. And patients will complain of a couple of things when they have this. Okay, there's actually lots of different things. David types too slow. So things that they'll complain of. They may feel short of breath. That's a good one, Alejandro. Are you sure you're a student? Because I don't feel like that's really true. I feel like you are not a student. You are very smart. Students usually don't know the answers that you are putting in. Okay, so just graduated. Wow, that's all I can say. So palpitations, good one, Teresa. Shortness of breath, good one, Alejandro. Patients will oftentimes complain of palpitations where they'll feel like butterflies are in their chest, or lots of things. If any female ever tells you I feel weak, or I feel tired, or I feel out of it, or any of those things, get an EKG, because AFib can present in all sorts of ways. Or sometimes people will say, dizzy, good one, Tanya, but also they'll say, I feel like I'm just out of steam. That's a thing, right? That's steam. And then there's the junction. There's really only one rhythm to worry about in the junction, unless you work EMS. Okay, if you work EMS, then you have to worry about the accelerated version of this, often seen after you push epinephrine. But this is something that somebody already said they had today, so that was pretty cool. And you know that because there's no P wave, and it's between 40 to 60. And essentially the AV node is in charge of the heart. Okay, AV node is in charge. And when the AV node is in charge, you know that something's happened to the sinus node. So one of the things you worry about would be that there was a lesion, a heart attack to the right coronary artery that feeds the sinus node. So junctional rhythms always kind of get me a little worried, especially if people are having chest pain. And like KJ said, there's no P. So question, what will you see if there's no P? What will you see in the PR interval? What will the machine put there? Pop quiz. We covered this last night if you were here, but just to review, what will you see? Okay, yes. David says, please remember, junctional rhythms are compensatory. Be careful treating these. And so, yes, Matt put it in the answer field. And asterisk, Teresa and Matt and KJ. Good job. Because there is no PR to measure. So yeah, this is actually, as David said, so there's a saying that I'm reminded of when we were paramedic, when I was training to be a paramedic, we were always taught sometimes the hardest thing to do is nothing. And this is one of those cases, right? Because you may be tempted to want to give them atropine, but you may want to do some more digging before you do, especially if they can hang in there while you sort it out. Okay, let's talk about the ventricles. The ventricles, nothing really good happens in the ventricles, to be honest. Premature ventricular contractions can come from the ventricles. They can be somewhat benign, although they can be not benign too. It depends if you have a lot of them. So David said, put your hands in your pockets. Yeah, that's the hardest thing to do. I'll tell you what. So this is one where you wouldn't want to put your hands in your pockets because this patient may not have a pulse. This patient, if they didn't have a pulse, what would we call this if they didn't have a pulse? And yes, this is idioventricular, Teresa, but if they did have a pulse, what would we call it? It would be, and again, we're probably not dealing with this always. So Nicole, Emily, Teresa, Michelle, yes, PEA, pulseless electrical activity. So you can still have an organized rhythm, but it can have no pulse. And if so, then you consider the PEA. Now it can, an agonal rhythm looks similar to this, but the key is that it is slower. An agonal rhythm is slower, less organized, because what's happening is a little lonely heart cell is down on the bottom of the heart trying to run the heart, and it's not designed to do that, so it's struggling. So it's going to do its best job it can, but it's never going to be enough, which is why it's going to be wide, because it's coming from the ventricles, right? Wide over more than 0.12 or 120, and agonal is less than 20 beats per minute. So you know their base, this is usually 20 to 40, and then 20 or less is usually agonal. So that's exactly what I put here. David and I are like so on the same page. And you can see that this is wide and bizarre, very unorganized. And that's just one little lonely heart cell at the bottom trying to pump the whole heart. It's a big job, and it's too hard. So if you see this, you're definitely calling David to come to your clinic, right? Ring, ring, David, come. And if you see this in the field, you're, getting out meds, doing CPR, all the things. But hopefully you're not seeing this in clinic. That would be really bad. Now, pop quiz. What's this? Speaking of things that come from the ventricles, hint, hint. What is this? Okay, let's see what answers we have. Okay, we have a VTAC answer. I know there's going to be a purist on here who's going to say this is a wide complex tachycardia. And you guys are both right. So technically we would do a 12 lead, right? We would do a 12 lead to see, but yes, wide and fast and regular is going to be VTAC until proven otherwise. So David says, I get called to clinics for abnormal EKGs almost daily. Wow. Wow. That's pretty amazing. Are these slides available for download? Alejandro, they are not available for download. You have the workbook that's available for download. If you want to join our 30-day EKG class, obviously you have PowerPoint School, or you can download. Highly recommended as a new NP, by the way. And that's a bunch of really, really good classes. So it is always VTAC first. Yes. Monomorphic. Yes, because it is going the same direction. If it had a twisting of the points, we would call it something else. We would call it torsades de pointe. I think I mentioned that last night with the prolonged QT, right? But essentially, wide and fast, we're always assuming it's VTAC until proven otherwise. But make sure it is regular. Make sure it is regular. And then this one here is so easy. Everybody should get this one, right? Everybody can get this one. All right, so what is this one? Okay, thank you for posting the link. I love it. Yes, Michelle McMicken, Michelle McMicken, you are spot on. Lynthia Bird, you are spot on. Matt, spot on. This is none other than the very bad ventricular fibrillation. So no pulse, they need defibrillation, they need drive fast therapy, and they need lots of drugs. So essentially, yes, the RP. Hey, what's up, RP? RP says Fibbin. Exactly. This is basically anarchy. Okay. So one fun thing is that when you have the heart and it is just going crazy, don't get a 12 lead. Exactly, David. Yeah, don't do that. So check your leads, check your patient. That's always going to be a rule, no matter how, they say that some of the Newsel monitors, it'll compensate for a lead being off. I'm still so old school. I'm like, no, check your leads, check your patient. If your patient's talking to you, it's not VFib. Okay, not VFib. And then, what people often think is that we're going to defibrillate the heart. We're going to restart the heart. We're actually not really restarting it. We're actually kind of slapping it, and all the cells are going to stop for a second because we're slapping it with energy. And then the hope is that the sinus node will pick up and take over again, and it will be it will be basically the sinus node takes over and everything's great. Does that happen very often? No, because it just doesn't. We hope it does, but it usually goes through asystole once you defibrillate. Okay, so let's talk about atrial or ectopic beats. Somebody asked me, I think it was on Instagram yesterday, but I'll cover it here. They asked me about beats that are multifocal. Okay, so a multifocal beat is beats that look different. So you've got this normal beat here and then an extra early beat that's wide. That is a PVC. And here's a normal beat, then PVC. But they look different. They have different faces. Okay. We have different faces, so look abnormal. Will you have the 30-day program? Yes, we will have it again. So you can always join us another time. We are not going anywhere. So good question. So multifocal, these are worse than unifocal, which are the same shape. Uni is coming from one cell, multifocal is coming from multiple areas. So that's a little worse and more concerning. And then let's go over the workbook together. And PVCs always have the QRS in a different direction than the T wave. Oh my gosh, another great pearl. David, I'm telling you, you are just full of so many good tips for new people and advanced people, actually. So this was, we covered earlier. I just wanted to throw that back in case anybody wanted to take a look again. But again, those are in the featured post. We are going to release, I think it's around 6:15. We're going to release the answers for day 2. They'll come up in the group, but we can go over them real quick. And these are in the featured post in the Facebook group. But let's go over these. Okay. So this is going along with your workbook. This is just so you can have the answer to make sure you get it. This is AFib. This is a recap of it's irregularly irregular. Okay. It's not RVR because it's not yet over 100. This is a sinus arrhythmia. Again, it's irregular, but still has P's, caused by breathing. This is an idioventricular. It's slow, usually around 40, can have a pulse or no pulse, and the wide bizarre over 120 milliseconds. And I'm showing you all this because tonight when Gary comes on, he's going to show you random strips. I don't know which ones he's going to choose, but I want you guys to have this fresh in your mind so you can like be rock stars and answer and like just knock his socks off with how smart you guys are. And then junctional, this is of course still narrow, coming from the top. The AV node is running the heart, no P wave, and that's the junction. Okay, so these are our top rhythms that we covered today. And we now have time to talk about the prize. Okay, so after during Gary's session, I'm going to give you guys a hashtag, and then I'm going to pick a bunch of people that are going to win these, but we'll do that during Gary's session. So when he's talking, I can be writing your names out on a piece of paper, and I can just draw your names live, and you can see who's going to be the winners. So that's super exciting. So we'll be back on the same Zoom in literally 15 minutes from now. So if you want to hop on, you can. If you feel like you got everything you need to hear, that's okay too, especially if it's late on the East Coast. David put another pearl, sinus arrhythmia looks like an accordion. Also, one thing I just wanted to mention is that we're giving away a scholarship tomorrow night, but I haven't seen anybody who's going to win yet. So I need you guys to really like kick it up a notch because I want to give away a scholarship tomorrow night to our 30-day EKG challenge. You really want to win the scholarship. Yes, same Zoom link. You want to win the scholarship. Here's why. You get a month-long access to all the live classes where we do basic EKG, EKG workshop. You have access to everything that's been recorded in the past 3 years, every class we've done. You have access to all that for 30 days with us. Who would not want that? How can you enter to win? All you have to do, it is so easy. If one of your classmates is struggling, or if you see somebody in here in this group that's asking a question, help them. I'm looking for that. I want to reward the person who helps other people because that's how we are in this group. We are a big team, but I don't want you guys to be shy. I want you to help each other. Last time KJ won was so helpful was when somebody asked for a Zoom, KJ was right there when they were like, hey, tag me in the live, KJ was right there. So we want to give away a scholarship tomorrow night. Please, please, please come through for me, you guys, so I can give away this ticket. And David does do custom classes to the questions you want answered. He's doing one tomorrow. So if you do want to sign up, the link's there. Get in the class. You'll be able to go live with David tomorrow and see the amazing magic where he's going to deep dive on the basics. Speaking of basics, we're going to do one more night tomorrow night, and we're going to cover basic 12 lead. So it's going to be a pretty short class tomorrow night. So don't worry. I'm going to try to keep it around a half an hour as well. And it will be recorded. So even if you're busy and you can't make it, we will have a pre-game with Michelle. And Michelle, do you want to tell us a little hint of what's to come for tomorrow's game? And Alejandro, the class with David is in our 30-day EKG challenge tomorrow at 2 p.m. PST. 2 p.m. PST. So Michelle, do you want to tell us about the game?
Yes. So tomorrow, yeah, can you hear me okay?
Yeah.
Okay.
So
Yeah,
tomorrow,
I am going to,
yeah, can you hear me?
sorry, I have an echo. Tomorrow I'm going to have probably start off with we do the Zoom and Facebook game, I think, the space game. So sorry, I have a terrible echo. I apologize. Anyway, so tomorrow I'm going to have a game between Zoom and Facebook. So people jump on Zoom and half the people on Facebook, and we will compete with each other to who can type in the questions the fastest. And it's going to be a space game between Baby Yoda and Zebra.
Oh my gosh, you're so creative, Michelle. So do you want to tell them why Baby Yoda, in case people don't know? Why Baby Yoda? That's so random.
Of course, when I started with teaching with Jennifer, that was what everybody was talking about. If they were just learning EKGs and they were still kind of at the beginning phases, they were Baby Yoda. And as they got more into learning the EKGs, they became Mandalorians, which everybody wants to be a Mandalorian like David. And we're not there yet, but at least we can all encourage each other. So the main thing is, we like to encourage each other, and Jennifer uses the zebras to make sure that we're looking for things that we wouldn't normally see in patients, those little tiny things like the T waves.
Exactly. Well said. So you guys don't want to miss out, because Michelle also does heart voices, as KJ mentioned. They're really fun. So if you want a fun session, be here at 5:30 Pacific Standard tomorrow. Michelle will kick us off, and then we'll wrap up with the basic 12 lead and hopefully give away a scholarship. Michelle says she's a Baby Yoda. You know, it's so funny because we have lots of Baby Yodas, but I want to tell you an inspiring story. We had a paramedic student come in, and she was so nervous when she first came, and she would call herself a neonate Yoda. So cute. We didn't even have that term, but she's like, I'm a neonate Yoda. But she just this month came and lectured with me in person to nurses, doctors, and PAs and Ps, and rocked it. She came so far. So literally, you can do it, even if you're a Baby Yoda. And David said he's not a Mandalorian, but yeah, you so are. You so are. I have to work tomorrow night. The games are yes, it's recorded tomorrow, so don't worry, Lynthia. You can totally watch it later, no problem. It'll be in guides day 3. And Alejandro says, thank you so much for having these courses. EKG has always been my weak point. Yeah, you can come back later. We'll be here. So anyway, we're gonna let you guys go, get a drink, eat whatever you want to do. We'll come back at 6:15, and we'll do some practice. So I really want you guys to come and like knock Gary's socks off, just like be on top of it. So that means, Teresa, you definitely have to come, because you're always getting the right answers, of course. So we'll see you in 15 minutes back on the same Zoom. Won't be recorded, so show up live if you can, and we'll be giving away the prizes on Gary's session. Okay, bye guys.